Good morning, everyone. My name is Jackie Klotz, and I want to welcome you to our webinar by Dr. Stanley Williams. Dr. Williams is here to share his experience integrating NMDOH screening and resource referral through the Health Home program at the Harris Center for Mental Health and IDD. He will describe how they navigated the new screening process into program staff workflow, connected patients with resources based on need, and evaluated health outcomes to demonstrate the NMDOH program impact. We are so happy that you have all joined us today to hear from Dr. Williams. That we don't have time for introductions, we hope everyone will take a moment now to introduce yourselves in the chat, tell us what you do in the NMDOH space. To tell us more, I want to introduce our consortium director, Dr. Charles Mathias.
Thank you, Jackie. I'm glad that you've all made it here today to join us for this webinar. Just as a reminder, this meeting is being recorded, and we'll share out a link with you to our YouTube channel after the presentation, so you can catch it there. And we'll also share out a PDF of the slides from today's presentation. There'll be time after the presentation for questions and answers. So as you think of things, drop them in the chat. I'll be watching that. And after the presentation, we'll have time for folks to come on the mic and ask their questions. I'm very excited and honored to introduce our speaker today, Dr. Stanley Williams. Dr. Williams is the Director of Integrated Healthcare at the Harris Center for Mental Health and IDD. The Harris Center is the largest local mental health authority in Texas, providing over 2 million services to nearly 96,000 individuals across 80 locations in the Houston area. In his role at the Harris Center, Dr. Williams directs 4 integrated primary health and behavioral health outpatient programs in partnership with the University of Houston Tillman Family College of Medicine. He has previously been appointed by the Texas Lieutenant Governor to serve on the Texas Peer Support Stakeholder Group, which led to peers being certified in Texas. And he is a co-chair on the Mental Health Subcommittee for over 140 organizations for the Harris County Health Equity Collective, working on improving conditions of health disparities and health equity, as well as development of a health exchange. Please join me in welcoming Dr. Williams, who is here to share his experience with the practical steps to integrating NMDOH screening and referral programming. Dr. Williams.
Yes, thank you, Charles. I'm so excited to be able to present about non-medical drivers. I know it's been probably challenging for a lot of people about what are non-medical drivers of health, how do you create a culture for it? And I'm hopeful that after I'm finished, that you'll be able to gain something from our experiences. Now, am I actually up right now? Okay. Trying to get my other screen up. So, Jackie, do I have?
Yes, if you hit the share screen button and then select the page, it'll come up on our screen. Great, we can see it.
Okay, great. So now I can get going. So let's lean in. I'm very excited about this presentation. So when you think about, non-medical drivers, you have to have a team. And so we have Janet Martinez and Teresa Pettigrew, who's our cornerstones in being able to implement some of our integrated health programs, and in particular, our Optum behavioral health program, which has been very exciting for us to actually work with Optum, United Healthcare, on that project. So let's talk about the lessons, objectives. So we want to know, what is the why? When we move forward with trying to integrate non-medical drivers into our systems of care across the different programs that a lot of you work at. The first thing you have to do is ask yourself is, why are we doing it? A lot of times you hear people say, yeah, we do SDOH, we do non-medical drivers, but what exactly is that to kind of create a culture and actually a delivery of care that kind of incorporates that? There's been a lot of discussions about non-medical drivers of health, about what are the benefits of it. And for us and everyone here collectively, we want to be able to show the benefits of non-medical drivers as it really impacts care delivery. How it improves the outcomes for the individuals, how it's able to demonstrate to payers, about how non-medical drivers of health can kind of improve the bottom line in reducing the cost of care. So we want to be able to describe the framework that we use and kind of our lessons learned in that. And we want to describe really how that was implemented within our health home, as well as our food RX program. So as Charles mentioned, the Harris Center is the largest mental health center in Texas, one of the largest ones in the country, with over 88 sites, over 90,000 people served, quite a few languages. It's really multi-diverse staff and really diverse population that we serve in Greater Houston. So when you think about the non-medical drivers, we kind of approached it by several different ways. One is evaluation. Why are we doing it? And how do we adopt it within our agency? And then we wanted to look at assessment, and then what is the interventions that can be used to actually show application of non-medical drivers. So the first thing we want to do is take a step back and kind of look at what are these non-medical drivers. And actually it has its roots back in Maslow's hierarchy of needs. This is important to understand. All of us went through something during the pandemic, and some of us in Texas went through something with the hurricane. And so when you think about these types of experiences that affect the human dimension, it really impacts us on the emotional, social, physical level. And this hierarchy of needs kind of addresses that. So if you look at the philosophical, physiological in terms of food, water, shelter, safety, these are kind of the main properties, if you think about, that folks really have challenges with when different things happen in their lived experiences. And the other thing that we have to look at is, when we begin to address the human dimension of what people are experiencing in their day-to-day living, it really begins to develop a relationship with them when you begin to engage them. This is so very important. Our field of behavioral health and even in primary care, we're so caught up in addressing people by pathology, by diagnosis, and so forth. If we don't address what are some of these non-medical drivers that really cause these types of conditions in people, then we really lose out and begin to blame people and begin to have biases toward people, because we all have experienced these different levels of needs in this hierarchy. And like I mentioned, just think back during the pandemic, okay, and what we all experienced in that period of time. So when you think about some of the literature, there's tons of literature out on non-medical drivers of health, and just want to invite everyone to begin to do literature searches on what are the social determinants of health. That's the language that's used by the federal government oftentimes. So just make sure that you're understanding that when they say social determinants of health, here in Texas and a lot of places, we use non-medical drivers of health. And so when we look at that, there's a lot of research on it. It's going to be very important to understand, what are the impacts on non-medical drivers and what does some of the data say about that? And that's one of the things that we did internally is did really sort of this literature review of what are non-medical drivers. Then we began to look at our own population. And so when you look at people with behavioral health conditions, the average age that they die is 53 years old. And the reason being is because of some of the issues related to untreated health conditions like hypertension, diabetes, obesity, cardiovascular disease. These conditions actually have an upstream factor that can be dealt with to kind of reduce the pain and suffering that people go through associated with these chronic health conditions. If we could begin to look at some of the non-medical drivers, everything from access to care, which hampers a person's ability to be able to achieve wellness. And then you talk about the medication adherence. Do they have access to be able to purchase their medications in terms of the costs and so forth. And then you talk about the preventive medicine that's needed in treatment that actually is kind of these upstream approaches that would reduce the mortality rate that's kind of really a disparity for people with severe mental illness. So when you think about the non-medical drivers, there are factors, and you look at the impact, 20% is related to access to care. Those are things that we can help control and can help engage individuals with to reduce that. These are upstream factors. So when you think about some of the physical factors and social determinants factors, 80% of that drive health outcomes. And so those are the things that we began to look at, is that when you think about these different domains of education, job status, income, community safety, and then you look at the health behaviors of tobacco use, diet, exercise, a lot of these things are related to behavior. And one of the things that we can impact are individuals' behaviors if they can have a navigator or somebody can help them to navigate some of their challenges and so forth. So when you look at assessment, we wanted to look at what does it mean to assess non-medical drivers. And so one of the things that we wanted to look at was internally, what is happening with our population. So one of the things with non-medical drivers is a whole framework related to population health and risk stratification. And one of the things that we did was during the time of COVID, so this was a survey that we did between April 20 and April 2021. I'm gonna give a shout out to Dr. Hickey. I think he's online. He's one of the ones that helped us put this together. And then also to the staff, when you think about non-medical drivers and the engagement factor where care navigators and healthcare professionals are going out to engage people to find out what's going on with them, it takes a lot of courage, especially during the time of COVID. So I want to applaud our staff and the work that they did in order to engage clients on a one-to-one basis, sometimes individually, sometimes virtually, to be able to gather this data. And so this survey went out. The survey was based on the Prepare tool and asked some questions related to food insecurity, related to economic insecurity. And this is some of the data that we found out, is that roughly 35% of our folks felt that they would run out of food. A lot of our folks were uninsured. A lot of them had real economic insecurity. And this was really, even though the COVID was there, some of these conditions were there pre-COVID. And so then you add COVID on top of that, then you're talking about some real serious challenges. Some of our clients are still experiencing not being able to really come back from that period of time because of the losses that they experienced, let alone the death of a lot of family members and so forth, and trauma and all kind of experiences that people had from that period of time. I think this period of time really helped promote it, what the importance of digging deeper in terms of our evaluation process to be inclusive of the social determinants of health as we began to engage people. When our staff went out there to engage clients, it wasn't really based solely on, do you have a mental health diagnosis and what is your pathology that's going on related to that? It was really related to their lived experiences. And that is so important as you begin to engage people, because then they see that you see them and that they matter. And so the other thing that we did was kind of a snapshot about what's happening in our organization related to health concerns. And we had a lot of health concerns. Part of our protocols is that we screen people when they come in on blood pressure and BMI and things of that nature. And you know, digging a little bit deeper, we're finding out that a lot of our clients didn't have access to care. There wasn't a lot of preventive medicine. There was a lot of real challenges of our clients being able to access care. So think about the data that's, you know, that I presented earlier, that the average age is 53 years old, that folks die. A lot of it has to do with these kind of conditions that are not really dealt with in an upstream fashion. And so when you think about health disparities and their association, we're talking about access problems. We're talking about high rates of physical and emotional wellness challenges and mental illness, premature mortality, some real high cost of care associated with this. When folks don't know how to navigate the systems of care, some of the work that we found out is a lot of our clients actually will go into the emergency room, because think about it, you can get care. You don't have to set up an appointment. So that's why the high cost of care with emergency rooms and where folks were not able to be dealt with in an earlier upstream fashion because they couldn't navigate, they can go into the emergency room. And that's where all of these challenges are coming. It affects everyone. And going into the emergency room isn't kind of a plush experience. You know, it's a waiting period and some real challenges associated with that. And so when you think about sort of this vicious cycle of unmet needs, you know, you're talking about people having serious problems, living alone, having problems to navigate, in and out of crisis and in emergency rooms, sort of this cycle of not anyone helping them to navigate our systems of care. And the concept that I came up with is this iatrogenic disease. So it's like we're providing care, thinking we're doing very well with it, but actually people are getting sicker. There's been a lot of things written about sick care because we haven't incorporated social determinants of health, preventive medicine, and other ways to help people navigate this vicious cycle. Our clients don't, and members within, you know, health plans don't want to keep going in the hospital. They don't want to have this vicious cycle over and over again. And it really affects them on an emotional level to the point sometimes where they then give up, don't access care, and then everything has a trajectory where they get worse. So we explored different types of assessments and interventions. There's quite a few that are out there. CMS actually had a lot of things related to the accountable care communities, Prepare tool. A lot of the FQACs use the Prepare tool, which is a very good tool. Here in Texas, I just want to give a shout out also to Texas Council of Community Centers, where they really push this effort on non-medical drivers, and where all of the mental health centers now use the American Academy of Family Physicians tool for social needs screening. So very important. And Texas Health and Human Service has done research associated with the impact of and importance of social needs screening and addressing the non-medical drivers to improve the overall wellness of people. So just having a tool is not going to help you unless you have kind of this pathway of how to use it. One of the things that we did was that we incorporated that tool within our Epic EHR system. We have pathways to care where our care coordinators and assessments and screening incorporates the social determinants of health and non-medical drivers to be able to begin to target what the needs of the individuals. We use that as a basis to address kind of a plan of care for the individuals. So when you think about it, you know, when you think about non-medical drivers, we have to redefine what is specialty mental health. It's not just mental health. It has to be inclusive of the non-medical drivers, the social determinants of health, in order to kind of remove these barriers and improve access to care and address the health disparities. This is so very important in order to get to the point of preventable hospitalizations and ER admissions. So let's talk about some interventions that we've been able to do. But before we go to those interventions, you have to have partners to do non-medical drivers. You can't do it alone. You know, you can go up there saying, we're gonna do non-medical drivers, but if you don't have a relationship with food banks, and it's not just food banks, there's a lot of, and I know there's probably people here not in Greater Houston. We have some wonderful resources with the Houston Food Bank, and I think they stretch outside of Houston, but also there's some local groups, church groups, and other groups within your community that you can reach out to find what kind of resources are in the community to kind of create those collaborative partnerships to be able to engage people. Because identification of the non-medical drivers that's not the end of it. Then you have to be able to say, what are we going to do with the knowledge base that we've gained from the individual? And also collectively with your population, because you want to do a population health approach related to non-medical drivers so you can see trends associated with that can help you out with your planning and so forth to actually begin to meet those gaps in care. So let's pivot to our health home. This is a partnership with Optum Health and United Healthcare. And so this project, we were one of 4 nationally. There was another one in Texas. And when we first began to engage them, you know, we looked at, you know, what were some of the goals associated with this. And of course, it's to reduce the hospital readmission. It was be able to do follow-up after hospital. Our state is real familiar, I think, with doing 7-day, 30-day follow-up after state hospitals, but they wanted us to concentrate on private hospitals. And a lot of folks that have Medicaid and Medicare that aren't able to access, you know, care after going into the hospital or the high cost centers. And so the pilot had 1,500 members from Optum. Only 25% of them were our clients. $100,000 worth of claims for each of the members or more. And that was a challenge for us because this approach wasn't just related to behavioral health. It was people that had co-occurring health and behavioral health conditions. And so things that we looked at were some of the readmission interventions related to homelessness, lack of transportation, access to care, a lot of different challenges that folks had when we began to go through the records of these 1,500 members of what their needs were. And so one of the things we had to do was create a kind of a flow chart. I know this looks real busy, so I'll try to break it down real quick. You know, we had to identify people, it's called the Integrated Behavioral Health Home, if they were going to opt in or not. The big part that I wanted to look at is once they opt in, we began to address this health action plan. Social determinants of health was really the key. One of the things that we had identified with this was that when we had all these screening tools, we weren't really making connection with the clients. So we had to pivot, and just want to thank the folks from Optum United Healthcare. And what we decided to do was just address the social determinants of health, and then months later get into some of the other screening tools, because this was their greatest need when we began to work with them. So with that, in terms of that population health approach, we wanted to look at those based on those social determinants of health factors and stratify based on high, medium, or low risk. And then based on that, we identified the kind of interventions we would do based on those severities of need. Then we would go into addressing, you know, the other issues associated with them, creating a care plan and so forth. But what allowed us to build a rapport with the clients and the members was that social determinants of health evaluation. It was critical. So then we needed to create a kind of a methodology of how we would use the social determinants of health, analytics and so forth. And what we came up with was sort of looking at data. So Optum United Healthcare actually had claims data and so forth, which we were able to look at if a person needed to have a refill their medications and so forth, if they had some other challenges related to being in and out of the hospital. So we got that that claims data report like daily. Our staff would look at it almost like just the data streams over and over again in our daily huddles. And that was so important for us to be able to do that. From there, we began to look at from the huddles, what are some approaches to be able to deal with like the social determinants of health, resource referral, and follow-up. So we had to create a whole framework of what are the resources associated with what we identified with the needs. We began to do that. Some of the issues we identified were stages of change, motivational counseling, some of those things like that. And we had to realize that there were some non-traditional hours in scheduling in order to meet with the clients and what their needs were. Coordination of care with their medications, hospitals, ERs. Also, we worked with urgent care centers to be able to see folks in lieu of going into the hospital, ER, if that was a need based on what they presented. They were able to identify that. We taught self-management skills and so forth, address, health promotion, wellness strategies, coaching. All of that was ongoing with our clients. So what I mentioned earlier, there was kind of this utilization of a Optum portal in terms of the data streams. It was almost like I mentioned earlier, almost like the Matrix, when we're looking at this movie Matrix. If some of you are familiar with that, it's like the green things and those streams of data coming down. Our teams were actually looking at data like that all the time, look at how they can dispatch and address the needs and gaps in care. And so, we had, I think for non-medical drivers to be able to really get on the map and to get recognition, it has to have a connection with improving outcomes. And so that's one of the things that we did. So our outcomes are these HEDIS measures related to follow-up after hospital, diabetic eye exam, ambulatory care they get into their providers, in terms of their rate of going into readmissions and so forth. We found out a lot of folks, there were cases where we had a woman who had prosthetic leg, and she couldn't get to her appointments because she was sharing her prosthetic leg with 3 other men, okay? Now just think about it. These were men that it was fitted for, and she was a woman. So those are the things that you're able to begin to drill down when you begin to look at what are the needs of the individual and what is stopping them to get to this level of wellness. So this is some of the reporting that we came from them. We're very proud of the work of our staff and the participation of the members. In terms of medication adherence for medications, all planned readmission. These were the quarterly reports that we did with them. This is the reports that came from Optum United Healthcare, and we achieved that. You get certain points for that. This is a value-based shared savings program where we got paid for meeting our points, and then also shared saving will reduce the total cost of care. So I want to pivot now to the Food RX program. We're really excited about that. To date, we started this in April. We've had over 1,000 people of our clients come through now, over 25,000 pounds of food delivered to our 4 different sites for the food trailer. This program really is based on food insecurity, but also we get baseline information related to poverty, chronic health conditions, and so forth. And what we had to develop is kind of a mapping of how we use that in terms of our waiting room experience when folks come in. And the treatment area is really where we give the social determinants of health American Academy of Family Physicians social screening tool. We use that for the basis of delivering care. Our case managers incorporate that in terms of their follow-up and finding resources in the community. But you definitely have to have a flow of how you're going to use the screening tool. So part of that evaluation are the two food insecurity questions that we asked. We actually did this for our population as a whole to identify the specialized needs of this population. And when we did the population health, we identified that population based per site and then began to work with the Houston Food Bank to develop this program. In this program, eligibility, you have to meet the hunger of the vital signs, the food insecurity questions. Our staff began to identify other needs with the individual associated with economic challenges, transportation problems, issues of access to care, and so forth. So a lot of work went into this, a number of months. This just didn't happen overnight. Our staff really worked very well with the Houston Food Bank. Houston Food Bank, to shout out to you folks in terms of the training that you did with our care navigators and our peers to be able to understand the importance of being able to get really baseline information. So we address daily living assessment, do a financial screening, we do a quality of life screening. We ask the social determinants of health to hunger, vital signs. We also pull data related to blood pressure, diabetes, other baseline information. And so we use that in every 6 months. We'll be able to look at improvement in care. And this is a part of the 6-month part that I was talking about. 4,000 clients, 25 pounds of food so far per month. Okay, I don't know if I have enough time to show the video. I can try it.
Yeah.
In a world
Can you
where
hear
we
it?
often take the simple act of having enough food for granted, there exists a hidden struggle that affects millions: food insecurity. It's more than just the lack of access to food. It's a barrier preventing individuals from living active, healthy lives. Studies have shown that food insecurity not only impacts physical health, but also mental well-being. The risk of anxiety, depression, and even suicidal thoughts skyrocket in those facing this daily battle. Through a 2021 survey, the Harris Center found that almost 35% of respondents believed they would run out of food each month. Our regular community needs assessments will allow us to continue to track this issue for those we serve and offer a solution that gives hope and stability.
We got potatoes, onions, carrots, pork, bananas, pistachio nut. Well, it means a great deal because, you know, some people don't have money to buy food, so this is a good thing. I wish, you know, they say they're gonna keep it up, so come out and enjoy.
I'm Nicole Hong. I am the Health Partnerships Liaison at the Houston Food Bank. I'm working under the FoodRx program. So FoodRx is a program by the Houston Food Bank in partnership with healthcare organizations all over Houston as a means to help patients receive food and worry less about putting food on the table and focusing more on managing their health.
We're real appreciative of the partnership with the Houston Food Bank, with Nicole and their team. And so one of the things that the Harris Center is looking at is food as a strategy. And so this whole partnership is actually what we call food RX, food as medicine. And when you think about our population, they die 25 to 30 years earlier than the general population. It has to do with health conditions, untreated diabetes. Our clients live in food deserts. They don't have access to food. And so some of the things that we did as far as the preparation for this is that we do a non-medical drivers kind of screening to look at some of the risks. And so these are the folks that have actually identified having problems with food insecurities. And so this actually helps us to work with the whole person and be able to provide the resources to improve their overall health.
Okay, I'm gonna stop sharing. I think we're at close to 11:40, and I can answer questions and turn over to Charles and for your thoughts.
Thank you, Dr. Williams. I appreciate that. I'm just checking in the chat. I see Irene Cazares had a question, and Irene, if you want to unmute yourself and just come on and ask your question.
Yes, I work for Behavioral Health Integrated, and one of the things we were interested in was the survey, how he did the survey. I really like the food RX. That was interesting, and I think I'm going to end up sharing with my higher ups to incorporate that, because I'm the one that does that social determinants through the integration of behavior.
Excellent. Yeah, I think I can get with Dr. Hickey. We put the survey together. It was based on a prepared tool, but I think we can share it with other folks. And I guess if I'm trying to figure out how I can get in touch with you. I guess my email is part somewhere, Jackie or Charles, that you can send it to me.
Put my email here.
Okay, in the chat.
Yes.
Okay.
Dr. Williams, speaking of survey, you had a great response. How did you get so many folks to complete that?
Yes, a phenomenal response. So think about during COVID, 2020, right in the middle of it, there was a lot of fear, a lot of concerns about what we're going to do and so forth. And one thing that became really clear is that there's different types of organizations and institutions within communities that can be a stabilizing force. And we realized that we were one of those, along with churches and schools or things of that nature. And our case managers, that was their priority during that season, was to reach out and contact their clients. And so that, they were very, they had a lot of courage and able to do that, because remember, we didn't know the impact on us. I mean, they wore masks and things of that nature, but it was really due to our leadership, our case managers, and behavioral health leadership that actually facilitated that.
Great. And I'll let folks go ahead and raise your hand if you have any questions. I'll keep an eye on that. I'll just ask another question that I had, which was about your partnerships. Now imagine a number of those organizations already were touching those clients and serving them in other ways, but then in forming the partnership, what's the added benefit of now having something more formal in place?
Yeah, that's a very good question, because the Houston Food Bank has access all over. I mean, they have partnerships with churches and other places like that. Our clients have a real challenge with navigation, and then also have a real challenge of trusting certain institutions also. And I think just having, we know they came to our sites for their treatment and so forth, and why not expand the scope of supports that we provide them, not only our pharmacy, but also our treatment, engagement, and then also now the Food RX program.
And I see a hand raised. Alexander, do you want to unmute and ask your question?
Yes, I actually do have a question. I was wondering, is there a specific way that you streamline like referrals to your partnering organizations, or is that, because I've seen that you guys use Epic? So is the SDOH work complete just being done through Epic, like referral wise? Is there another way that you guys are streamlining those referrals?
Yeah, so right now, I mean, one of our charges is doing what we call a closed loop referral. So our staff is really working hard with kind of the manual way of doing this. Our hope would be is that Houston Health Equity Coalition is really moving toward this kind of health exchange. It will allow us to do that closed loop with community-based organizations and providers. That's our hope. We're kind of in a pilot coming up in the coming months with that. My hope is within a year that we'll be able to streamline that. I think connectivity to other organizations are very important. I think this project with Charles, Jackie, Rice University, Elena, this type of work I think helps promote the idea so that when folks do contact people in the community, they'll say, "Oh, okay, yeah, I've been attending those meetings." There's opportunity right within this forum to begin to communicate and create streamlines. So.
And I see a question in the chat. I'll ask if Noah Wineflash can come on unmute and ask your question about health plans.
Yeah, sure. So I'm curious, I know you shared that
Mhm.
you are in partnership or contract with Optum and I forget, maybe someone else.
United Health.
Is it fairly universal that all of these large health plans really are investing in this infrastructure? Or did you find a way to identify that those two orgs were open to it and you started pursuing partnerships with them?
I say it's the former. The health plans are very familiar with non-medical drivers. They're looking at the research associated with reducing the cost of care, improving client experience and so forth. And they've already identified that. And so health plans are very interested in this. If you can create kind of a pathway of care, I think that their interest is going to be associated with the outcomes. And so those outcomes associated with, for instance, medication adherence. If your care navigators are engaging the client, knowing when their medications are needed again, making sure they take their medications, the idea of addressing the food desert situation with folks, if they can, we worked with this one individual that had high blood pressure, and this is a case-by-case situation, and found out they were eating a lot of peanuts, okay, and they loved peanuts, and we talked about some options with that. I think that the key would be is for non-medical drivers, there's going to be a population that's going to be higher risk. That higher risk population translates to higher cost of care. If you can begin to identify strategies and have the motivation to work with that higher needs population, managed care companies can be very interested if it translates to reducing the cost of care and improving outcomes.
Got it. Thank you very much.
Mhm.
Anyone else has questions, please raise your hands. I'll just follow up on that one. I think one of the things that struck me is just how successful you were in kind of closing the loop between operation, screening, implementation, and then the outcomes that you could show back to plans. So you talked about first, it felt like the matrix with all that data. How did you kind of work through the point of like making this actionable where you had that story, that through line?
Yeah, it's definitely our team. One of the things that our team, Teresa Pettigrew runs our Optum Health Home program, and they've really have developed a culture. Some of it is staffing. Some of our staff had been caretakers of family members that have been ill, who understood the importance of taking their medication and the relapse of what happens to their overall health when they don't take their medications, and beginning to hear the stories. So it kind of evolved to the point when we began to hear some of the needs of the individual, and we realized we need to create that methodology, that I kind of showed you, the concierge model, where we look at data, and from that data, we're able to set assignments for staff. Staff broke out in different areas, some related to follow-up after hospital, some focused on follow-up with primary care, some focused on some specific social determinants of health needs. And as when you begin to look at your team to do different assignments associated with a population health need, that's kind of how we got to that.
Great. I see another question from Irene Cazares. Irene, you want to come back on and ask that about partnerships?
Yes, well, like I said, I really like the food RX. We do have HEB here in the Valley that is almost in every town, but I don't know if they go all the way to corporate to ask on who is that resource that can assist, especially the clinic that we're in. It's an imaging clinic where they can provide aside from just food bank, because we do have a food bank that comes every other month.
Mm-hmm.
The hot months, it's been very difficult to try to just generate the people to come out and be with the heat.
Some of the food bank folks, and we've talked to the Houston Food Bank folks, have looked at maybe you develop a pantry if you have the space that'll allow you to work with the food bank to do more regular drops and be able to have greater access to your clients. That might be one area to kind of explore. I know we're, this project with non-medical health consortium maybe spreads into some rural areas. I'm not sure. Charles, what is the catchment? So some of those areas may not have the resources. And I think it may mean sitting down and creating a collaborative related to social determinants on a local level, identifying who are the resources and folks that can be part of that, to include some local church groups and so forth. If you don't have the access to the food pantry space, then maybe a church group or another group can do that, where you're sharing those resources within the community.
And Irene, I'll just add that on July 30th, we're actually having a webinar on this topic of partnering with local food banks, and it'll showcase several different food banks, so you'll get some different perspectives there. And additionally, some of our partners in the consortium, especially those with the UT Center for Health Equity, really do a lot of this work in the food space, and probably could expand on what Dr. Williams is talking about with the different levels and approaches to getting food access.
Unfortunately, that day I will not be available, but if you can share the recording with me, I would appreciate that.
Yes, if you go ahead and register for it, it will come out to your email through after the webinar.
Thank you.
We have a couple of minutes left. I'm not seeing more questions, answers. Dr. Williams, I wondered if you wanted to just get into something we were talking about earlier about your patient example. We've got about 5 minutes.
Let's see if I can share that again.
We see it.
Okay, do you see the big screen or the little screen?
Right, yeah, it's not in presentation mode, it's in
Okay.
edit mode.
Let me see.
Yeah. There we go.
Okay. Can you see that?
Yes. Perfect.
So this is an interesting case study. I actually used this about 5 years ago, changed it around a little bit since then when I was in East Texas and Longview, working with a community collaborative there about social determinants. But the case is Mr. Bean is a case manager with 80 people on his case list. He thinks he has a number of people on his case list like Will Ferrell. Will, 58-year-old man who resides in a private house with his wife in Houston. The house has been in the family for 5 generations. They need new paint inside. There seems to be a strange odor. The once thriving middle class have been infiltrated by opioid dependence, unemployment, poverty, employment reductions related to technologies and the oil business. Most of Will's neighbors now live below the poverty level. He has inconsistent transportation, recurrent hospitalizations for major depression, diabetes, chronic health conditions, and so forth. Dr. House, his doctor, thinks Will Ferrell is not taking his health and depression medications consistently and needs help with the opioid addiction. Will, the patient, tells Mr. Bean, his case manager, Dr. House doesn't need to worry about me. I know I got this sugar. I mean, I do a lot of things I'm supposed to do, but I have a lot of things going on in my life and nobody even understands, like my kids are always hungry. Mr. Bean tells Will, you got a lot of problems. You are just a depressed person. That's why you don't want to do anything for yourself or your family. The patient gets angry and speaks to Mr. Bean's supervisor and says that no one understands what I'm going through. I didn't just get depression. That's not who I am. Will Ferrell gets a new case manager. His name is Kevin Hart, to be the care coordinator. Mr. Bean, the former case manager, tells Kevin Hart, you won't be leaving early today. Will lives in a bad neighborhood. Will probably need to be readmitted, and the mobile crisis team will be furious. He needs to take his meds, but don't believe him. And he gets sick with probably eating all those fried foods. All these folks are the same. They don't want to get better. So this scenario, I was trying to get to the point where over a period of time, care navigators get numb to the human needs of people. They cross-talk about the patient. They're not connected with the real human needs of the individual. And to the point where a person may have to get another case manager. And then even there's some crosstalk about that. And so sometimes in those scenarios, you're going to have to be a leader and recognize, kind of what's happening. So the question is, what would you do if you were the supervisor or the new case manager, Kevin Hart? Is kind of the way we would deal with this in discussion.
Thank you for that powerful story. I think it really drives home that, this process of addressing the NMDOH is really a journey over time. It's not something that we address once and then move on to other things. So thank you for sharing that.
Now, I just want to show this last one that says trying to provide behavioral health treatment without addressing non-medical drivers and health disparities is like spraying greater and greater quantities of pesticides on crops growing in unsuitable soil that plants will not thrive. So.
Thank you. Well, just being mindful of the time, we're close to the top of the hour, and I just want to turn it back over to our program manager, Jackie Klotz, for closing us out.
Thank you, Charles. And thank you, Dr. Williams, for a really illuminating presentation and discussion today. Before we wrap up, I wanted to direct everyone's attention to the consortium's NMDOH Program Index, a single repository of NMDOH programs across the state that are sponsored by health system organizations like plans, providers, and hospital systems. It features abstracts of programs with searchable fields, and our goal for this index is to serve as a resource for anyone working in this space to know what is happening, what is working, and with what costs and benefits. But as we've discussed, the program index will be as robust as we make it. So I'd like to invite you to contribute this effort by connecting with me to add your program index to the NMDOH to add an abstract of your NMDOH program to our index. The link to the program index is in the chat. Please click this link and bookmark it for when you can set aside some time to take a look. Our next learning session will be Thursday, July 30th on partnering for health strategies to establish local food bank partnerships. So check out our events page, driversofhealthtx.org, to register. Thank you again for a robust conversation today. We are grateful for your input, and we really want your feedback on this webinar, so you will be receiving a short survey along with the recording and PowerPoint slides over the coming days. Please stay in touch with us. You can always reach me at jk90@rice.edu. Thanks again, and have a great rest of your day.
Thanks, everyone. Thank you, Dr. Williams.